afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation titled Mostly Worse, Occasionally Better, the First Wave of the COVID-19 Pandemic and the Mental Health of Children and Adolescents in Ontario. My name is Sarah Carsley, and I'm the Applied Public Health Science Specialist in Healthy Growth and Development, and it's my pleasure to be moderating today's session. Before we start with today's presentation, a few housekeeping items. We will remain in lecture mode for the duration of the call. If you have any questions, please send them through the chat pod located in the bottom right of your screen. In order to hear this presentation, it's strongly recommended to log into the audio via a landline or cellular device. The quality of the audio may be affected if you choose not to log in through this manner. I'd like to state that as the moderator of this session, I do not have any potential conflicts of interest to declare. It's now my pleasure to introduce the speaker for today's presentation, Dr. Catherine Tombow Cost. Catherine Tombow Cost is a research associate in the Department of Neurosciences and Mental Health in the Research Institute at the Hospital for Sick Children. During her PhD in New Orleans, she worked with rats, studying cognition in pregnancy and motherhood. Accepting a postdoc position in Toronto, she worked on the Maternal Adversity and Neurodevelopment Project, or MAVEN, studying maternal cognition and maternal behavior in humans. Catherine applies innovative statistical methods to understand the differential contributions of biological, psychological, and sociological variables to parent and child mental health. Thank you so much for being here today, Catherine. I will now turn it over to you.
Thank you so much, Sarah. So good afternoon. Thank you for tuning in today and for sharing your lunch hour with me. And thank you to Dr. Sarah Carsley for inviting me here today. I'm a researcher at the Hospital for Sick Children, and today I'll be discussing some of our recent findings on the mental health of children and adolescents from the first wave of the COVID-19 pandemic here in Toronto. But first, I need you to know that I have not received any financial support or in-kind support from a commercial sponsor, and that I have no other conflicts of interest to disclose. Next, I'd like to introduce you to our team. So here we all are, the Ontario COVID-19 and Kids Mental Health Study Team, with myself, Dr. Alex Chirac, Dr. Catherine Birkin, Dr. Jennifer Crosby, Dr. Sunita Mangar, Dr. Evdukia Anagnostou, and Dr. Daphne Korjak. We've received funding for this project from the Sick Kids Center for Brain and Mental Health, the Leong Center for Healthy Children, the Department of Psychiatry at the University of Toronto, the Ontario Ministry of Health, and the Canadian Institutes of Health Research. I'd like to acknowledge our whole team for this great work and to our funders for supporting these efforts. Now I'd like to introduce you to our learning objectives for today. First, I hope you will become familiar with what is known about the impacts of public health measures on child and youth mental health in a global context. Second, you will learn about the rates of deterioration and improvement in child and adolescent mental health during the first wave of the pandemic compared to before the pandemic right here in Ontario. Third, you will be able to identify the variables most strongly associated with the deterioration and improvement in child and youth mental health during the first wave of the pandemic. And finally, we will explore together ideas about how to ameliorate or improve mental health for children and adolescents during subsequent waves of the pandemic, like right now. So first, here is what we know from other countries. We know that in Hubei province, where the pandemic first hit really hard, that children had increased prevalence of symptoms of depression compared to neighboring provinces in China. But we also know that across China, children and adolescents experienced higher rates of depression and anxiety symptoms compared to before the outbreak. In Japan, which at the time of the data collection was experiencing less severe disease impact, younger children had an increase in peer problems. And in Germany during the first wave, children and adolescents experienced a decreased quality of life and an increase in anxiety. And finally, in the United States, which has been very impacted by COVID-19 from the very beginning of the pandemic in April, there was an increase in behavioral health problems in children and adolescents. That brings us to what we don't know. We don't have much insight into the impacts of the pandemic on mental health domains beyond depression and anxiety. We also don't know if different age groups are differently affected, which might be expected given the developmental differences across childhood and adolescence. And we don't know much at all about how kids with pre-existing mental health diagnoses might be affected, especially because these children and adolescents might be more vulnerable. Lastly, we don't really have a good handle on what is driving the mental health changes. Is it about disease prevalence? Is it about compliance with emergency measures? Or is it about changes in the social landscape that children and youth are experiencing? And those questions bring us to our unique collaboration, including 4 cohorts with one goal. We have 2 cohorts that include clinical samples, the Province of Ontario Neurodevelopmental Disorders Network, or POND cohort, and the Sick Kids Psychiatry Research cohort. We also have 2 community cohorts, the Spit for Science cohort, representing children and adolescents enrolled at the Ontario Science Centre, and the Target Kids cohort, representing younger children enrolled through primary care practices. These 4 cohorts came together early on in the pandemic to improve our understanding of the mental health and well-being of children, parents, and families in Canada during the COVID-19 pandemic. Our very first objectives were to get a better idea of mental health in domains beyond depression and anxiety. So we examined the prevalence of mental health status change, and I'll explain what we mean by that more in a minute. But basically, did someone feel they were doing worse, the same, or better during the first wave compared to before the first wave? So we asked these questions of parents, and we asked the children and adolescents themselves, starting at age 10 through age 18. And we asked about depression and anxiety, but we also asked about irritability as well as attention, hyperactivity, and symptoms of obsessive-compulsive disorder, or OCD. Our second objective, once we had these prevalence estimates, was to examine what factors might be associated with deterioration, or doing worse, and with improvement, or doing better. For this objective, we considered the differential impacts of compliance with emergency measures, so things like staying home and washing hands, but we also considered the stress associated with social changes, like not being able to see friends, or not being able to experience milestone events like graduation or a school trip. And we considered COVID exposure for the child or a family member. Meanwhile, we also included in our model household income, the economic impacts associated with COVID, like job loss, the assigned sex of the child, the age of the child, the race or ethnicity of the child, and whether the child had any premorbid psychiatric diagnosis. Our data collection began on April 15th and continues to run through to today and beyond. But these analyses considered data only from mid-April until June 19th, keeping in mind that by June 19th, the weather had turned fair and many regions in Ontario had come to phase 2 of reopening, with Toronto coming to phase 2 reopening on June 24th. Of the 1,902 potential participants who received an email about study participation, 1,013 parents agreed to participate and had completed the measures of interest, while 385 children and adolescents provided their perspective for the following analyses. Let's learn a little bit about the folks who participated in this study. We included children ages 2 to 18 years old, with an average age of 10.46 years old. About 60% of our participants claimed European ethnicity or ancestry. Our sample was relatively high income, with just under 73% making at least $80,000 per year. About 56% of the children and adolescents in our study were assigned male at birth. Around 62% of our participants had a previous psychiatric diagnosis, which could be depression, attention deficit hyperactivity disorder, anxiety, autism spectrum disorder, and/or many other psychiatric diagnoses. And about 4.2% of the participants had been exposed to COVID-19, either themselves or a family member having a diagnosis. Now that we know about the folks who participated in this study, we can get back to our first objective, to examine the prevalence of mental health status change in 6 domains of mental health, including depression, anxiety, irritability, attention, hyperactivity, and OCD symptoms. We used a frequency analysis with the frequencies summing up to 100%, or all of our participants. We had younger children, ages 2 to 5, whose parents responded to items on emotional problems, which represent anxiety, conduct problems, which represent irritability, and hyperactivity. We also had older children and adolescents, ages 6 to 18 years, whose parents responded to items on depression, anxiety, irritability, attention, hyperactivity, and OCD symptoms in their children. We asked participants to rate if their child was doing better, the same, or worse compared to before the pandemic. So if a parent rated worse for their child, we considered the child's mental health in that domain to be deteriorated. If a parent rated better for their child, we considered the child's mental health in that domain to be improved. And if a parent indicated their child's mental health was neither better nor worse, we consider them to be doing the same in that domain of mental health. We also asked children and adolescents, ages 10 to 18 years, these same questions to get their perspective. Which brings us to our first result. In our youngest children, ages 2 to 5 years, we see that about 2/3, or 67%, experienced deterioration in at least one of the 3 domains. While in older children, that number is marginally higher, with about 70% of children and adolescents experiencing deterioration in at least one of the 6 domains. While many children and adolescents experience deterioration, some children and adolescents did experience improvement. In the youngest children, around 31% experienced improvement in at least one of the 3 domains. This is a fair bit lower in the older children and adolescents, with only about 19% in this age group, 6 to 18 years, experiencing improvement in at least one of the 6 domains assessed. Now that we have an overall sense, let's look at this domain by domain. I want to start by orienting you to this graph, as we'll be looking at it for a while, and a couple different versions of this graph. So to start, along the vertical y-axis, we have a percent, which represents the percent of individuals experiencing each category of mental health status, summing to 100%, which is all the participants. Along the horizontal x-axis, we have each of the 6 domains in turn. And our color coding in the key at the bottom of your screen, with the lightest color blue indicating individuals who have experienced improvement in that domain, the medium color blue indicating individuals whose mental health in that domain remained unchanged during the first wave, and the darkest color blue indicating individuals whose mental health deteriorated in that domain during the first wave. So this graph includes all participants where possible from ages 2 to 18 years old, so we can get an overall sense. Then we'll break it down by age and by diagnosis next. So on the left side here, we have our first domain, which is depression symptoms. And we see that over 45% indicate deterioration, and around 12% indicate improvement in this domain. Our second domain is anxiety, with just over 40% indicating deterioration and only about 6% indicating improvement. Our third domain is irritability, with just over 45% indicating deterioration and about 12% indicating improvement. Our fourth domain is attention, with over 45% indicating deterioration and only about 7% indicating improvement. Our fifth domain is hyperactivity, with around 33% indicating deterioration and only about 5% indicating improvement. Finally, our sixth domain is OCD symptoms, with around 21% indicating deterioration and just under 4% indicating improvement, with the majority of children and adolescents unaffected by the pandemic in this domain. So when we look at this, the domain with the highest rate of deterioration across all participants was attention at 47.3%, followed closely by depression at 46.9%. And that is followed closely by irritability at 45.9%. This might not be what you had been expecting, and indeed highlights the importance of looking at domains beyond depression and anxiety. If you remember, one of the gaps in our current understanding was how different age groups might be differentially affected in terms of their mental health deterioration or improvement. So this chart, like the previous chart, including all children in the study from ages 2 to 18 years, with the vertical y-axis indicating the percent of individuals affected and the horizontal x-axis indicating the domains of mental health. But here we have it broken down by the age of the child and by the informant. At the bottom of your screen, we have the key, where the darker shades indicate deterioration, the middle shade indicating no change during the first wave, and the lightest shade indicating improvement. In the blues, we have parent report, and in the reds, we have child or adolescent report. This chart is a bit much, I agree, especially as we zoom through this presentation, but there's a couple of key takeaways from this Toronto skyline of columns. The main takeaway is that if you look across all ages and all informants and all domains, with the exception of OCD symptoms, you can see that it is roughly 40% of children and adolescents who have experienced deterioration during the first wave. The second takeaway is that there are some domains that show a bit more variance by age group and by informant than others, notably irritability, which seems to be affecting younger children, ages 6 to 12, a bit more than adolescents, ages 13 to 18, or even the youngest children, ages 2 to 5. We also see a bit more variation in the hyperactivity domain, where there are some differences by informant, with parents of adolescents reporting more hyperactivity than the adolescents themselves, which is maybe not so surprising. So we can look at how all kids altogether are affected, and we can look at how kids across different age groups might be differentially affected. But we also have this really rich data set that includes 2 clinical cohorts. So we can also look at how children and adolescents with different types of psychiatric diagnoses might be impacted in terms of their mental health during the first wave. Again, just to orient you here, we are looking at children ages 6 to 18 with a vertical y-axis indicating the percent of individuals affected, the horizontal x-axis indicating the 6 domains of mental health. But now we have it broken down by the diagnostic category of the child. At the bottom of your screen, we have the key, where darker shades indicate deterioration, the middle shade indicating no change during the first wave, and the lightest shade indicating improvement. In the blues, we have children with a history of mental health diagnosis, including depression, anxiety, ADHD, among others. In the reds, we have children with an autism spectrum or developmental delay diagnosis. In the golds, we have children who have both a mental health diagnosis and an ASD or developmental delay diagnosis. And in the greens, we have children whose parents did not report any pre-COVID mental health autism spectrum or developmental delay diagnosis. Again, I realize that this is a lot to take in, so I want to bring your attention to specifically depression and irritability. These are the domains where we see the greatest amount of heterogeneity between children with a pre-COVID psychiatric diagnosis and children without a pre-COVID psychiatric diagnosis. In particular, more than 50% of children with a previous diagnosis are reporting deterioration in depression and in irritability, while 40% or just under 40% of children without a previous diagnosis are reporting deterioration in these domains. That said, 40% experiencing deterioration is still pretty alarming. So we can summarize these findings as follows. First, many children and adolescents experience deterioration during the first wave, and the highest rate of deterioration was in attention. Second, some children did experience improvement, but the rates of improvement were highly variable across the domains and also across age groups. But among the youngest children, ages 2 to 5, about 1/3 experienced improvement in at least one domain during the first wave. Third, among children with a pre-morbid psychiatric diagnosis, the majority of children and adolescents experience deterioration in irritability. Within different diagnoses, children with ASD or developmental delay and children with comorbidities, including ASD or developmental delay, experience the greatest rates of deterioration. However, even children without a pre-existing psychiatric diagnosis still experienced high rates of deterioration. Now that we understand a bit more about the prevalence of deterioration and improvement in the 6 different domains, we are ready for our second objective, which is to understand what variables are associated with improvement in a given domain and with deterioration in a given domain. We included 4 different COVID-related variables. First, COVID exposure. Second, compliance with emergency measures. Third, economic concerns brought on by COVID. And fourth, stress associated with social changes or isolation during COVID. We also included demographic variables on household income, assigned sex of the child, age of the child, race or ethnicity of the child, and the presence or absence of any pre-COVID psychiatric diagnosis. We used 6 multinomial logistic regressions to understand the variables associated with improvement separately from the variables associated with deterioration. So I'm going to walk through each of these domains separately. And I want to note that these results apply only to children ages 6 to 18 years. Now I want to orient you to how these results are displayed. Variables associated with improvement will always be on the left in the green panel, while variables associated with deterioration will always be on the right in the orange panel. Next, I want to draw your attention to the font size, which I have used to give you an idea about the strength of the association between a given variable and the outcome. The first domain is depression, indicated at the top of your screen in the title of the slide. Variables associated with change in depression. In the green panel on the left, we have variables associated with improvement, which include a previous psychiatric diagnosis and also lower stress associated with social changes or isolation. In the orange panel on the right, we have variables associated with deterioration, including previous psychiatric diagnosis and greater stress associated with social changes or isolation. And given the font size here, we can see quite plainly that stress associated with social changes or isolation are very strongly associated with deterioration in depression. Here we have anxiety, where we see female assigned sex, previous psychiatric diagnosis, greater economic concerns associated with COVID, and lower stress associated with social changes or isolation are all associated with improvement in anxiety. Now, if you're wondering if you heard me right, that greater COVID economic concerns are associated with improvement? You did hear me correctly. And we'll see that these economic concerns are also associated with improvement in other domains as well. But this is not to say that being worried about money, income, job status, or food is a good thing at all. But the reasons for why these kinds of concerns might be associated with improvement is something we can talk about during the discussion, as well as an area of ongoing study for our group. On the other side, we see that only greater stress associated with social changes or isolation is associated with deterioration and anxiety, but this association is very strong. In irritability, we find that only previous psychiatric diagnosis was associated with improvement. However, having European ancestry or ethnicity, older child age, a previous psychiatric diagnosis, and greater stress associated with social changes or isolation was associated with deterioration in irritability. Of these, the strongest association was greater stress associated with social changes or isolation. With regard to attention, only greater COVID economic concerns were associated with improvement in attention, while only greater stress associated with social changes or isolation was associated with deterioration in attention. For hyperactivity, our model in improvement was not significant, so we were unable to determine any variables associated with improvement in hyperactivity. However, we found several variables associated with deterioration in hyperactivity, including male assigned sex, older child age, previous psychiatric diagnosis, and greater stress associated with social changes or isolation. While all of these variables are significantly associated, the magnitude of the association is not as great as it was for other domains, such as depression or anxiety. Finally, we have OCD symptoms, where we find that children with non-European ancestry or ethnicity were more likely to show improvement in OCD symptoms. Also, greater COVID economic concerns again were associated with improvement in OCD symptoms. On the other side, we find that previous psychiatric diagnosis, again, greater COVID economic concerns, and greater stress associated with social changes or isolation were all associated with deterioration. So to summarize the findings from our second objective, we find that stress from social changes or isolation is strongly associated with deterioration in all 6 domains of mental health. And in anxiety and in attention, stress from social isolation was the only variable associated with deterioration. At the same time, children who experienced less stress from social changes or isolation experienced improvement in depression, anxiety, and irritability. We also find that premorbid psychiatric diagnosis is associated with improvement in some domains for some children, while it is also associated with deterioration in some domains by other children. To get a bit more detailed, a premorbid psychiatric diagnosis is associated with both improvement and deterioration in depression and irritability, which is to say that some children with a diagnosis experience improvement, while other children with a diagnosis experience deterioration. But it is only associated with deterioration in hyperactivity and OCD symptoms, and premorbid psychiatric diagnosis is only associated with improvement in anxiety. Finally, we find that economic concerns due to COVID are associated with improvement in anxiety and attention, and with both improvement and deterioration in OCD symptoms. Okay, so that is a lot of information, and some of it seems a bit counterintuitive. And so now we need to think about what this means and what we need to do to help children and adolescents. That brings us to our implications. The first big implication here is that many children and adolescents experience deterioration during the first wave. So what can we do to help children and adolescents adjust to life during a pandemic? How can we frame the pandemic so that children and adolescents can understand that this will in fact end, that the world is not stuck in COVID mode? Our second implication is that we found that stress from social changes or isolation was associated with deterioration in mental health. What can we do to make sure that children and adolescents are getting the social interactions that they need to thrive? We might want to think about ways to facilitate social interactions, and keeping schools open is one piece of that, but there are also safe ways to interact outdoors or over video chat. Third, we found that children and adolescents with a pre-existing psychiatric diagnosis were experiencing deterioration at higher rates than children without a pre-existing psychiatric condition, indicating that children with a pre-existing diagnosis may need more support to manage the impacts of the pandemic. So what can we do to really connect children and adolescents with the services that they need? And what can we do to make sure that existing services are not disrupted, whether those services are part of their experience in school, to a hospital or clinic, or respite care? Okay, now here's the one that requires a bit more thinking. We found that greater economic concerns due to COVID were associated with improvement in a few domains. There may be different reasons for these associations, possibly due to less work-life conflict, i.e., if a parent has lost their job due to COVID and they are receiving CERB or other benefits, the parent might feel less stressed by work-life conflict, may actually have time to spend with their child in a positive way or by helping the child with online school or other tasks, and not have to worry about immediate financial needs because of those benefits like CERB. But at the same time, the parent knows CERB won't last forever. It hasn't. And there's a push-pull there that may reflect some of the arguments for the benefits of basic income in terms of child development. One clinician I spoke with thought this may reflect a family pulling together in the face of an external threat, which in this case is not COVID, but is the economic concerns. There may be other insights we can gain as we look further into these data. But the questions remain, what can we do to make sure that families that need economic support continue to receive it? And what can we do to help families maintain work-life balance when they return to paid work? Okay, that is what we have found so far. But we are in the thick of several new analyses to bring a bit more dimension and nuance to these results. I'd like to thank all of you for attending and giving your time. I'd also like to thank all of the parents, children, and adolescents who participated in this research, and of course, our collaborative team working on the Ontario COVID and Kids Mental Health Project. Our funders, without whom this work would not have been possible, our supporters, including Public Health Ontario, all of the folks who have supported me throughout this project, including Peter Zapmari, and the research assistants working on this project, including Reva Schachter and Avalon Henry, who have answered so many questions and kept our data so tidy and neat. Thank you.
Catherine, thank you so much. That was exquisitely presented and very, very interesting. And I really appreciate that last piece you did with implications, because I think that's exactly what our colleagues in public health and everyone listening is really thinking about, of how to mitigate some of the negative consequences that these public health measures that are needed to, mitigate the transmission of COVID-19, but have shown negative effects to our, children and families that we support. So now I will move to the chat pod and answer any questions that those on the line may have. Please continue to enter these into the chat pod if you've not already had an opportunity to do so. I think we have one comment initially that is an interesting hypothesis of the mental health improvement with greater economic concerns. I agree. Okay, a little face validity from the crowd. So multiple attendees are typing. I actually am going to take my opportunity as a moderator to ask you a question. Your initial prevalence of having a pre-existing mental health condition was about 62%. Was that the whole clinical and community sample?
Right, so that's across all samples. So some members of our community sample may also have had a pre-existing mental health diagnosis, which of course doesn't exclude them from participating in a community sample. But of course the other two mental health cohorts would be enriched for previous mental health diagnoses.
So that's why it would be a bit higher than you would expect from a general population. Okay, just checking. So we have a question. Great presentation. Was qualitative information collected to get at the experience of children that contributed to improvement/deterioration?
Right, so we did collect a little bit of qualitative information through the survey. So one of the questions that was asked in the survey was whether or not there was anything positive that had come out of COVID for a child, but also this question was asked of parents. And so we do have some qualitative answers on it. Those data haven't been analyzed yet, but I look forward to digging into that qualitative piece a bit myself.
Thank you. We have another comment. Thank you, lost audio, but that was very informative. I actually have another question for you. Did you collect any parent variables surrounding parental stress or mental health in this study that would inform maybe some of the mechanisms?
Yes, we did. So we asked questions about parent mental health, including depression and anxiety. We also asked some questions about how the family might be functioning as a whole. And we also asked some questions about parenting styles and parenting stress, as well as, just different kinds of questions about whether or not work had been disrupted, or whether parents were working from home, or if they were not working. So things like that might give us some insight into what sort of mechanisms might be shaping these outcomes.
Excellent. Can't wait to hear about those results. Okay, so we do have a question here. Do you have any suggestions on how we can connect children and adolescents with services that they need?
Right. So this is something that comes up pretty often, I think. And I guess I would say my thought on it is that a resource navigator is probably one of the more effective ways of connecting children and families with the services they need. So if a resource navigator is available to you, refer families to that resource navigator. If a resource navigator is not available, I think one of the things I would encourage is referrals, but also checking back in with the families to sort of see if they followed up on that. Because especially if a family is experiencing distress or a child is experiencing distress, that might sort of tax the systems in the family and make it a little bit harder for them to organize, reaching out and following up and taking care. So I understand that everyone has a lot to do right now, and it's a big ask, but I would think that for the children who and families and adolescents who need care, just getting that sense that there's help if they're encountering barriers in terms of connecting with that care.
All right, thank you. Our next question is, were measures of stress controlled for in analyses? Given the self-report nature, I could imagine parents experiencing more distress may report more deterioration compared to parents who are experiencing less distress.
Right. So that is, it was one thought, and we did think that parents who are experiencing more distress might report more distress in their children. And there's work from another group that looked a little bit at this and found that, in fact, the children themselves, when the parents are more distressed, the children themselves will rate their stresses higher. So it's not necessarily a reflection of the parent's perception of the child's stress, but it can also be a reflection of living in a household with a stressed parent can increase the distress of the child. And we find some validation for this when we look at the child and adolescent report, and we found that that parents and their children were rating their better, worse, the same equally, right? So, so if a parent says, I think my child's doing worse, the child is also saying, yes, I'm doing worse in this domain, and same thing for doing better or doing the same. So we did find that similar rating between the adolescents or children themselves and their parents. And then there's also this other work out of Waterloo indicating that a distressed parent actually can contribute to a distressed child, and that makes sense.
Yeah, thanks. So the next question is, the study population has much higher average income than my community, as well as understandably a high percent of young people with a previous psychiatric diagnosis. I'm guessing that than the general population. Yep. What might we be able to extrapolate to the general population, if any, do you think?
So in terms of income, that's a little bit more challenging. I guess one of the things I would say is, you know, if you think of income as being an access to resources, and you say here are families with access to resources, and still we find them struggling. So what are the implications for families who may lack access to those kinds of resources? And those families may be struggling even more. So in terms of income, that's one thought, that that families who lack access to some of these resources may be struggling even more than those families in our sample who clearly have some greater access. With regard to the previous mental health diagnosis, yes, you know, in one of the slides I sort of split this apart by children who had a pre-existing diagnosis and children who did not have a pre-existing diagnosis. And, you know, one of the takeaways from that slide is that it's still around 40%. So even among children who don't have a pre-existing mental health diagnosis, you know, with the exception of OCD symptoms, we're still looking at around 40% of those kids struggling with deterioration in one domain or another.
Great. So the next question is, I'd love to know how the children's data was collected, in person, virtually, phone, and what supports were offered to them after the data was collected. So the data were collected over email because when we rolled this study out, it was not a possibility to collect the data in person. I know that for some of the families, they might have been contacted by phone, but the forms were all sent and completed over secure email. And in terms of, I'm sorry, the second part of the question. If there was any supports that were offered to them after the data was collected.
Yes, support. Yes, so this is actually another piece of our study, and this is ongoing, where we're looking at trying to understand what kind of supports children might need and how to connect them with those supports based on you know, where they are experiencing the greatest challenges in the different mental health domains. So looking at a little bit more precision medicine or targeted approach.
Excellent. Were there any differences based on geography? I think one person has asked, I think our family participated in the study, but we don't live in the GTA.
Right, so we didn't, I should say we haven't in this analysis looked at differences by geography, but I know that several of the work that's going on right now that people are getting their data analyzed for, are including information on postal codes to try and understand where there might be greater concentration of difficulties or less access to services and things like this.
A similar question here is, given the salient findings in the study, are there plans to expand data collection to include participants from diverse cultural, socioeconomic, and geographic backgrounds?
Of course, we always would like to recruit more participants, and there's even a link through on SICK's webpage about where participants might get more information.
Are you planning to expand this data to include, the variable of in-school versus virtual school versus homeschool? Excellent question. I also had a similar thing about how the return to school is going to work in your next data collection iteration, or what you hypothesize about that. So I added on to Jess's question, but hers was, are you planning to expand this to include school versus virtual school versus homeschool?
So we did ask a bunch more questions around school and how school was going, whether school was the virtual school, homeschool, or like a learning pod type situation, or in-person school. And we also asked questions about, sort of how learning was going, and about how different public health measures were being enacted in the schools. So those data should all be coming up pretty soon. And we're very excited to be collecting them now and getting the parents' viewpoint on it, but also the children and youth and what their experiences in the school. So if I had to guess, I would say that in-person school is probably a great boon for children's mental health, and that's simply based on being able to have those social interactions in school. If we think about all of the tiny little social interactions you have, whether that's with a teacher or with a classmate or over lunch or this kind of thing, those are the sorts of experiences where a child can feel really socially connected.
Great, thank you. Where there were parents of 13 to 18-year-olds and also 13 to 18-year-old adolescents both responding, were they the parents of the same 13 to 18-year-old adolescents that were responding? So did you have both dyads? Yeah.
Yeah.
Okay.
So we had both members of the dyad responding.
Our next question is, mental health was identified early by federal and provincial government. Money was given to support mental health. However, working in mental health, I experienced mental health service as almost stopping for some time. Was there any findings for decreased resources and deterioration in mental health?
Right, so that's one of the questions that we had when we see that particularly children with autism spectrum or developmental delay, or children who have comorbidities in their mental health. And we know that the schools were shut down, and we know that children often can access mental health resources through the school. So, this contributes to our line of thinking that it's very important that we not have the disruption of services for children and youth, because the closure of schools can represent a disruption of services, and that's again another area where we're beginning to analyze the data and have a look at specifically how disruption of services and where services were obtained impacted child and youth mental health. But that's one of the key pieces, I think, that comes out of looking at children with pre-existing conditions, is recognizing that they need access to services.
Yeah, exactly. For the children with a previously identified diagnosis, did the include whether treatment was affected or not, paused or modified therapeutic supports, and if this affected whether a domain deteriorated. So a very similar question to halting of services during the pandemic.
Yeah, again, this is something that we're looking at right now. I know Dr. Anagnasi's team is very interested in this piece of the puzzle, whether or not the service disruption and what services were available impacted child deterioration.
Thank you so much. Great presentation. I am a guidance counselor who connects daily with many at-risk students. What we are finding is that some of our students that have been diagnosed with social anxiety who have chosen to be learning virtually are thriving. Our concern is how these students will cope once they are back in the building dealing with the typical social pressures. Any thoughts on how schools can begin to plan for supporting students post-COVID? Great question.
Yeah, so, and this was one of the things that we found. We found that, you know, kids who had a previous mental health diagnosis might have been doing better in some domains. And part of our thought about that was, you know, it's an alleviation of this social pressure, right? You don't have to go to school and try to fit in and navigate all of these kinds of things. So if there's already social anxiety there, then yeah, they're going to be doing great and really thriving in this online environment, because it can be much easier to navigate socially in many ways. But in terms of planning for students and supporting students as they return to school post-COVID, you know, I think that there needs to be maybe some pieces integrated into education around this. And that's just my feeling about it, that if this is sort of part of education for all students, it can also help these students who may have pre-existing challenges. But, you know, I think definitely in access to services and supporting those students and recognizing and validating their experiences of, well, I liked it much better online. It was a little bit easier to navigate socially.
Excellent. And I will plug a PHO document that we have on trauma-informed practices for children, particularly around COVID and the return to school. So it's on our website, I believe. Thank you so much. This was so helpful, and I look forward to hearing about your future analyses. Wonderful. Thank you, Heather. We have one more person typing, or not. As well, similarly, have you seen any changes month by month? For example, in September with return to school. So will you be doing some temporal analysis?
Yeah, so some temporal analysis has already begun, and there do seem to be changes month to month. Of course, you know, things started to get a lot better during the summertime, and that's of course because a lot of the restrictions were lifted, but it also has to do with really nice weather and how much we all appreciate being able to go outside and during the short summer season here. And so, you know, I think that there are already some evidence from our group that there are temporal changes. Now, what happened in terms of September when kids are going back to school, and maybe some of the procedures in school might have been presented challenges for them, or been difficult for them in some ways. Those are things that we'll continue to look at. But right now our data are, we're still collecting. We want to sort of collect through the end of the year to see how, like, the first term went.
And Catherine, could you say again, is there a link where people can find out more about this at Kids Collaboration?
Right, so we do have some links that were just created yesterday. So for Twitter, I can maybe copy and paste some links into the chat. Is that possible?
Sure.
So here is a Twitter link that has a really nice graphic about these, the summary of these findings. And this is going to be Instagram, if you go on the gram. And then we also have a LinkedIn link here. If I can just paste that in. Okay, so those are 3 links where first you can see an awesome graphic that gives you a great summary of these findings. Basically, a lot of kids are experiencing challenges, and social interaction is really very important. But also links to Sick Kids webpage with more information about the study.
Excellent. And I will also retweet that from my Twitter, although I don't have very many followers. Anyway, okay, thank you so much. We have no more questions, and we're just about done on time. So I'd like to thank you so much again, Catherine. I'd like to thank everyone who joined us for today's session. It's great to have such participation online, and I really enjoyed that amount of time we had to take questions and discuss some of the implications. Again, thank you, Catherine. Please ensure to complete the evaluation form for this session. I also ask that you reflect on how the information provided in this session can be used in your current work setting. Have a wonderful afternoon, everyone.